Good morning. Dr. Kernstein, Dr. Rucker, ladies and gentlemen. My name is Yue Wen. I'll be presenting robotic anatomic segmentectomy and mediastinal nodal dissection for early-stage small cell lung cancer. So as we all know, lobectomy is the gold standard for curative lung resection for early-stage non-small lung cancer. Anatomic segmentectomy has been advocated as a curative procedure in select patients, specifically older patients and those with poor pulmonary reserve. But controversy still exists on the oncologic efficacy of sublobar lung resections. Our objective was to investigate the safety and oncologic efficacy of robotic anatomic segmentectomy with mediastinal nodal dissection with clinical stage 1 non-small cell lung cancer. So we performed a retrospective review of patients who underwent robotic anatomic segmentectomy from 2004 to 2013. Our inclusion criteria was clinical HACC stage 1 non-small cell lung cancer. We had preoperative staging by CT scan, brain MRI, whole body PET scan, and mediastinal staging by EBUS. Pathologic upstage rates were determined based on tumor size in the specimen and nodal involvement. Patients were followed for local or mediastinal recurrence, distant metastases, cancer-related death, and non-cancer-related death. We performed a statistical analysis to develop survival curves based on the Kaplan-Meier technique to determine overall survival, lung cancer-specific survival, which we defined as censoring non-cancer-related death. We also looked at how lung cancer-specific survival is affected by pathologic upstage, recurrence, and age. In addition, we performed a multivariate analysis with Cox regression to determine hazard ratios based for age, sex, overall upstage, tumor location, and tumor histology. So between 2004 and 2013, we performed 153 segmentectomies. 61 of these were for patients who had clinical stage 1 non-small cell lung cancer. This consisted of 31 men and 30 women. 10 of these were upstaged pathologically based on our surgery. That translates to a 16% upstage rate. This table shows a distribution of our histology, which is expected. The majority of patients had adenocarcinoma followed by squamous and adenosquamous. Mean tumor size was 2.14. For 3 centimeters or less, we had 71%. If we're looking at 2 centimeters, it was about 52%. This is a table shows the distribution of our segmentectomy location. The purpose of this slide is to show that we didn't have a bias toward any specific segments or any tumor locations. Of note, the middle lobe and the lingula, we counted those as lobectomies. Our mean operative time was 134 minutes, median length of stay 7 days. We had 2 planned conversions to thoracotomy, and this was due to proximal involvement of the pulmonary artery, which required a thoracotomy prior to resection or repair. On the other hand, we had no emergent conversions to thoracotomy. We had an overall complication rate of 29%, but the majority of this was atrial fibrillation, pleural effusions. There were no major complications. 30-day mortality was 0. We had a mean follow-up of 30 months. This ranged from 2 months to 9 years, and 50 patients out of 61 were available for follow-up, so they were included in our survival data. So this first Kaplan-Meier curve shows our overall survival and cancer-specific survival. The red line shows the overall survival at 43%, and the lung cancer-specific survival, which is censoring non-cancer-related death, is 55%. And this includes our upstage patients also. When we look at upstaging, if the patient wasn't upstaged based on tumor or nodal involvement, their survival at 5 years was 73% for cancer-specific survival. If they were upstaged, this dropped significantly down to 0 by 5 years. Looking closer at nodal upstaging, if you did not have nodal upstaging by 5 years, you were 63% survival versus 0, and you can see a drop off there too. We also looked at recurrence or distant metastases and their survival based on that. If you did not have either of these, you had a 72% survival, cancer-specific, and based on distant metastases, this drops off. We didn't show the curve for local or mediastinal recurrence because there were only 3 patients that had this. Translate to 6%, but I just want to comment that we felt that this was this way because we had a R0 resection based on our mediastinal dissection and anatomic segmentectomy. by the robot. This sums up pretty much all our survival data. The main point is the first blue line is if you were not upstaged, basically if you were pathologic stage 1 non-small cell lung cancer, you had a 73% survival. Otherwise, things drop off a lot. In our multivariate analysis, we found that sex, sidedness, and histology were not statistically significant and didn't have strong hazard ratios. However, age and upstage did. If you were older, your hazard ratio was 4.4 and you had a p-value of 0.03. This suggests that younger patients do better, even from an oncologic standpoint. In terms of overall upstage, it's a big hazard ratio of 15.0001 p, so I think this, you could see from the curves that that was significant if you had any upstage on your survival. Limitations of the study was it's retrospective. It's a small cohort of 50 patients, and we did not have a comparison group to lobectomy or different approaches. VATS are open. Conclusion, robotic segmentectomy and mediastinal nodal dissection for stage 1 lung cancer is a safe procedure. Low morbidity and low mortality. It's oncologically efficacious. From our data, we showed a 73% 5-year lung cancer specific survival if it was true pathologic stage 1 disease. It's also associated with a 16% upstage rate. This is combined tumor size and nodal. If you look at nodal upstaging, it's probably in the order of 10%. And then based on our multivariate analysis, younger age and pathologic upstage are significant factors in lung cancer specific survival. So the next thing is this study should be the impetus for a multi-center randomized prospective trial looking at robotic segmentectomy and mediastinal dissection in all patients with stage 1 non-small cell lung cancer. That's it.
Any questions from the audience? Yes.
Ralph Schmidt from Bern, Switzerland. We know each other from the posters yesterday, so I know the data. If you would be very consequent, these patients that were upstaged and the 3-year survival was 0, I think, you shouldn't operate them. So you should improve the staging, invasive staging or mediastinoscopy, and then not operate them, if you would be very consequent, you know?
So it's, I guess the difficult thing is how do you accurately clinically stage a person before operating? Because
you only stage them clinically.
Yeah. So I think that's important to be able to do that accurately. But I think everybody that's presented during this conference has shown that you still get some upstaging pathologically. The question why, are you asking why our patients that are upstage don't survive?
No, why you wouldn't do not only a clinical staging, but mediastinoscopy or more invasive staging to exclude these basically 70%. If it would be really consequent, you know, we would say these patients shouldn't have been operated because if it's 3-year survival is 0.
Yes. I think that EBUS does give you a good sampling. Mediastinoscopy can't get the deep subcoronal nodes or anything N2 that are deeper, 8 or 9. So in our opinion, we thought EBUS, and we had early cohort of mediastinoscopy, did a good job. In addition, some of the upstage rate was based on tumor involvement too, just the size of it. So going from stage 1 to stage 2, despite imaging showing that it was not that large of a tumor, it still happens. So I guess we just have to keep trying to stage better.
How many lymph nodes did you say you had in the?
So when we take our lymph nodes out, a lot of it depends on the pathologist, honestly. They have a good range, but we clear out everything. Part of our surgery is to start with a mediastinal dissection. And it helps us actually see the bronchovascular structure, so it can really isolate things.
Is mediastinoscopy done with this or not?
We don't perform it. Yeah, we feel EBUS is pretty good.
So the American College of Surgeons this year recommended that at least 10 lymph nodes be counted in the specimen. What was the number that was counted?
We didn't look directly at that, unfortunately. But it would range sometimes from 5 to 20. It really depends on what the
Because you wonder if you had more nodes counted, what the frequency of upstaging might be in your patients. The other question is, I don't remember what the local versus the systemic recurrence and the combined rate was. Do you have a sense of that?
So local recurrence occurred in 3 patients, 50, so it's 6%. And then distant metastases was in 11 of them, so it was probably 28% total. If you look at the distant metastases, the majority of them, 7 out of 11 were actually upstaged. So if you were upstaged, then you were more likely to get metastasis.
Okay. And then do you have, remember what the cell type was? I mean, if these patients were, say, you know, an adenocarcinoma in situ, a minimally invasive adenocarcinoma, and you might have more of those patients that might be younger, for example, and that may be the reason that you're seeing better survival in the younger patients. That's probably a confounder. Age is a surrogate for something else, the decision to make a segmentectomy, rather than the true nature of the biology.
I think it would be interesting to look deeper into the histology. We mainly blocked it into adeno versus squamous. We don't have that data.
Okay. Yes.
Can you clarify what you meant by the planned thoracotomy? Do you mean that you went in with to stage the patient and then planned right from the outset to do a thoracotomy because it was a central tumor, or were these patients that you had an elective conversion because you were failing to progress, or something that was going on?
Yes, thank you. Some of these patients, based on their imaging, it's unclear if it's truly going to be a simple resection, if they're how proximal they are. So we like to use the robot as a diagnostic tool initially. We're still planning for the segment, but there's a chance that we may have to convert if it's involving a major vessel.
Great. Thank you.
Thank you.